Hey, good morning, everyone. Thank you for joining us. We see folks still populating in, so we'll get started in just a moment. Welcome. I'm on the West Coast, so it's still morning here, but good afternoon to those joining from elsewhere. Okay, I'm going to go ahead and get started. Again, welcome to this webinar. My name's Kevin Roy, and I'm here on behalf of Shatterproof. I've spent 8 years as Chief Public Policy Officer for Shatterproof, and now working in this capacity and as a consulting role for Shatterproof. What we're excited to do is welcome some really terrific panelists to share some information about access to behavioral health in the primary care setting through the collaborative care model. And we're going to have Q&A at the end of the session, and we'll get to as many questions as possible. But we may not get to a number that come in as we go live. A number were submitted in advance as well. So thank you for those that did that. And we also thank you for joining, and want to just remind you that the call will be recorded so that we can share this with others, after the fact. So I'm going to go ahead and just jump right in. Some really context setting at Shatterproof. I first became aware of the collaborative care model in 2019. And what I was really excited about at the time was the fact that it could serve a variety of needs in the primary care setting, which really resonated with me in terms of the fact that we knew addiction was undertreated, and that it was often difficult, according to to the NISDA, the National Survey on Drug Use and Health, its annual survey about people seeking treatment. And it resonated with me that finding people sooner, where they're potentially more comfortable in the primary care setting, could be really, really helpful. And so at the time, only 14 states covered the collaborative care model codes. And from there, we started talking with a number of states, and one of the concerns I think was pretty readily addressed was that turning on these codes would drive up costs or anything. The experience at the time, which is borne out over the years, is that's not the case at all. It's almost the opposite. Really, it's a really slow uptake. There's real investment of time and business resources on the part of a provider that wants to do the collaborative care model. And so that really didn't happen then, and it certainly hasn't happened in the intervening years. However, there are a number of it's a terrific model because it improves outcomes and is actually shown to reduce total healthcare cost. And so some of our panelists are going to talk about that very issue. And in the intervening years, we've had a number of states start to cover the code. So there's 35 states that now cover the codes. And part of the genesis of this webinar was to share an update on what has that meant for coverage. And so our first panelist, Michael Uhas, is here as representing the Bowman Family Foundation. And I'll just comment, the Bowman Family Foundation has just done a wonderful job over the last few years of really identifying data gaps that we as advocates were looking for, such as who was uptaking the codes, what were the outcomes. And so they've done several really, really important reports, one on suicide risk reduction, so a real world evidence study that showed the collaborative care model reduced the risk of suicide. Another report on the total cost of health care, and then, of course, this progress report on the collaborative care model. So with that, I'm going to turn it over to Michael, and I'll also add the other panelists here. We really wanted to present not just on the report, but also have a perspective of a state that's implemented not only the model, but has leveraged its own resources to improve uptake, as well as through West Health with Dr. Woodall has been able to implement it at a big provider network scale. So let me turn it over to Michael. Thank you again for joining us.
Thanks, Kevin, and thanks everybody for joining this morning. As Kevin said, my part here is really to kind of create a snapshot of the model, how it's been applied, how it's getting applied, and some of the trends that we've seen through the Bowman Family Foundation funded studies. And importantly, following me, we will have two presenters that will really get to the meat of what many of us want, which is to hear how it's been implemented, particularly at scale, and what kinds of things have we learned from that we can benefit from. So with that, next slide, please. So in terms of access, we have a crisis in terms of accessing mental health substance use treatment in this country that is becoming more and more acute, more and more recognized. And this slide just highlights the fact of why it's so important, and particularly in Medicaid, since Medicaid is the largest payer for mental health substance use care. But also the research that we've seen time and time again is that mental health substance use comorbidities will drive medical healthcare costs significantly, and we'll look at that briefly. And also, because of the nature of the problem, we're not going to fix it quickly enough by creating more specialists in the near term. We have to be very thoughtful about how we can leverage the system we have to create greater access. So this has all created a greater level of attention and scrutiny on the adequacy of mental health networks in every organization. And because most Medicaid beneficiaries are enrolled in some managed care plan, it's important that NCQA has begun to note this through accreditation standards that relate to assessment of network adequacy specifically for behavioral health. So for all these reasons, it becomes very important to try to get smart quickly about increasing access. Next slide, please. This is to the point about the mental health substance use comorbidities. This came out of a Milliman study that was published in 2020. And if you look at the red numbers on the right, the 3.2, 5, and 6.2, these are just the factors, the increased factors from having any mental health condition, any use condition, or both mental health and substance use. So anywhere from 3 to 6 times the medical surgical costs accompany these conditions. Next slide, please. One comment on this. This reflects commercial. The Milliman study reflects commercial, but the same trends are seen elsewhere. This is a well-recognized source. Okay, so through CoCM, collaborative care, there are different ways that we can increase access, but again, we're not likely to do it by increasing the number of practitioners who are licensed in the near term. It's just not practical. And so what is practical, though, is integrating behavioral health care, mental health substance care, into settings where patients already are going, meaning primary care. So collaborative care really leverages the existing primary care system, and it's really uniquely positioned. The process you see here, patients prefer primary care for their treatment. Behavioral health and physical health conditions are often very closely intertwined. And most of the outpatient psychiatric or mental health substance use care plus psychiatric drugs today are given in primary care settings anyway. And in rural areas, it may be the only game in town. At the same time, as we think, have become pretty knowledgeable about, primary care docs are not necessarily well equipped and not comfortable providing mental health substance use care to their patients, even though they want to, they'd like to, they know they need help, they refer them out. It could take any number of weeks to find an in-network provider. So what collaborative care does is really lets the primary care doc retain responsibility for treatment, for all of the treatment for the patient, but provides a support system through a behavioral care manager who provides coordination of care, brief intervention, med management support, as well as a psychiatric consultant, typically a psychiatrist, but not necessarily. It could be a psych nurse, and other states may allow other individuals to fill that role. But the care manager and the psych consultant are the kind of the expertise provided to support the primary care team. Measurement-based care, measurement-informed care allows the team to systematically monitor, measure progress, and treat to target. And then the patient registry is another requirement under the collaborative care. And as we talk about collaborative care today, particularly as I'm talking about the AIMS model, that many of you, if not all of you, are familiar with out of the University of Washington. So it is a well-documented model that just makes a ton of sense to us in terms of using what's already there. Next slide, please. So why CoCM in particular? I've already mentioned it increases access and makes efficient use of clinical expertise. A psychiatric consultant, for example, can positively improve the well-being, the mental health well-being of more patients than would be possible if that consultant were delivering traditional psychiatric care. It's a low-cost intervention. If you have 100% of Medicare reimbursement for it, you'll see it for maybe a $500 to $700 range for a typical course of treatment, episode of treatment, collaborative care. The evidence base, over 90 randomized controlled trials and other studies have all consistently pointed to the positive impact on patient outcomes. As Kevin mentioned, and I'll highlight again in a minute, the reduced suicide risk has been documented with collaborative care, including reduction of more than 50% of risk in at-risk patients that are defined as at-risk up front. And then reducing total healthcare costs. I'll come back to that in a minute as well. And then again, with adequate financial reimbursement, it is a self-sustaining model. So all of these reasons, there are other ways of integrating behavioral health care. We recognize that, and we do not think that there are no value at all. We just have found the evidence base is overwhelming for collaborative care. And as this slide points out, it seems like a natural way to leverage the system. Next slide, please. Okay, I mentioned suicide. This is 3 studies that came out of Concert Health, University of Pennsylvania, Penn Medicine, and Kaiser Permanente. In Concert and the University of Pennsylvania, you'll see over a 50% reduction that they showed. Each of these studies showed in reduction in suicide risk. The Kaiser Permanente study, which is the largest, over 200,000 patients, showed 25% reduction in suicide attempts and deaths versus risk itself. So very compelling, very important findings that, again, Bowman Family Foundation was involved in helping to put this study together, but the results are clear. Next slide, please. Touch again on total reduction in healthcare costs. There are 4 studies that came out of a brief that Bowman Family Foundation put out last year. And these studies were done. Impact goes back to 2028, the original Impact study looking at collaborative care. But we included the follow-up study. The original one followed people for a year. But the 2008 study went back and followed those patients for over 4 years and actually found that initially the collaborative care model wasn't showing dramatic impact at the beginning, but over the course of the 4 years of the study, it increased consistently over that time. The Kaiser Permanente study showed a 13% PMPM reduction within a year. Arkansas Blue Cross Blue Shield, I'll come back to this in the next slide. It's a recent slide, but showed $340 per member in 6 months reduction in total healthcare costs under CoCM. And then the Penn Med, along with Independence Blue Cross study, showed a 29.35 cent, a $30 PMPM reduction in a year. I will point out that was not statistically significant, but it was notable. It's a pretty significant number, just wasn't statistically significant. So taken together, if you look on the right side, a couple of the quotes, intervention patients from the Impact study at lower costs than usual patients in every category. Next slide, please. Okay, so this goes back to Arkansas Blue Cross. I just wanted to highlight this because it's very recent from last year. It's the largest of the studies, the 4 studies that we cited. And among the 13,000 patients that they monitored during this 2023-24, 10% ER reduction, 33% hospitalization reduction, 3% increased adherence to pharmaceuticals. And again, a $340 member reduction in 6 months following CoCM beginning. Okay, next study. I'm sorry, next slide. So I wanted to talk just for a minute or two about the trends that are going on that we saw in a paper that Bowman Family Foundation released in February. The National Claims Database, including commercial, Medicare, and Medicaid claims. For 2018-24, we looked at all the commercial claims. For Medicare and Medicaid, it only went out to 23, but otherwise, it's the same general period. Key findings: rapid growth, but I'll say being the top two states in terms of use per 100,000 patients with an MHSU diagnosis. But even those, the top two, are still only 1%. This is per 100,000 patients. So fast growth overall, which we'll come back to, but still huge opportunity for greater adoption. The second finding, tremendous, enormous disparities among states. You can see some states with virtually no commercial use, others had dramatic growth over the period of time. Patterns for Medicaid and Medicare were similar to commercial. Wide variation in reimbursement rates, again, Medicaid and Medicare. So while this growth is seen nationally, among states, there's just an incredible amount of variation that we are thinking about what can be done to reduce separation. Last point is just what many of us already know, but we looked at who is really providing collaborative care. And while it is changing, even as we speak, it's still predominantly family internal medicine and pediatric providers. We're seeing more and more collaborative care being delivered through specialty medical settings these days. But these 3 points taken together are 3 big takeaways. Next slide, please. Okay, in terms of the national growth, if you look on the left, this is commercially insured, right is Medicaid, CoCM patients, all CoCM patients in both cases. And you can see the dramatic growth in commercial from 12 to 317 over that period of time. And from 18 to 23 at Medicaid, you've got a tenfold increase. So on a national level, the increase is substantial, but again, tremendous room for opportunity. I would also add that for children and adolescents, I did not include those in this slide deck just for time, but I would say that what we see in kids 6 to 11, the rate of growth has been way more than we see overall. Same thing with 12 to 17 aged children in CoCM. So the rate of use has grown tremendously in Medicare, commercial, for adults and for children alike. Next slide, please. Okay, in terms of a little bit more depth on the examples of disparities, if you look at in 1304 per 100,000 commercially insured patients with a diagnosis in Arizona, this was an 11-fold increase from 2018. Wisconsin showed a 65 times increase from 18, and Utah showed a 338 time increase. So again, all growing, but the rate of growth is tremendously different in many states. Medicare, Medicaid, these top numbers I just walked through are commercial, but Medicaid and Medicare, we didn't have it available for this slide, are very similar, disparities that we'll see. And then in 24, commercial rates were less than 50 per 100,000 patients with a diagnosis in 16 states. And what we saw in those states was most of them did not post fee-for-service CoCM reimbursement rates on their websites as of January when we were doing this research. So, we looked state by state at all of the websites across the country for Medicaid to see who was, providing it under Medicaid and how they're reimbursing. Most did not post, most of the 16 states. Others did not have Medicaid fee-for-service during some of the years examined, at least some of the years. And almost all had low Medicaid, very low Medicaid use through 2023. So again, we're talking about commercial rates, but in the lowest, use commercial rate states, we're seeing Medicaid is consistently a factor in explaining different. Next slide, please. Okay, so commercial reimbursement. We look state by state, and you can see they range from 90% of Medicare to 277% of Medicare, with the U.S. national rate being 162% of Medicare. And this is for commercial reimbursement for collaborative care, state by state. And the interesting things here, if you note on the left, adequate reimbursement for commercial reimbursement for collaborative care is very important, but many of the states have high or very good reimbursement commercially for collaborative care, but not as high utilization as you might expect. And in those states, many of them, you'll see the blue boxes are ranked 25th percentile or higher, or 25th or higher out of 50 states in terms of commercial reimbursement, but nonetheless had low Medicaid and commercial use. So once again, we're seeing this tie-in between whether Medicaid reimburses for collaborative care, how adequately they do, and what that means to commercial and even Medicare utilization of collaborative care. Next slide, please. Okay, so this is Medicaid. I just showed you commercial, and as I said, we looked at all of the states as of January 26, and on the left, you'll see 4 groupings, 1, 2, and 3, and 4, which are showing rates of reimbursement. So 14 of the states paid more than 90% of Medicare for the 4 billing codes, 99492 and 3. 13 of the states are in group 2. So they paid 70 to 89% of Medicare rates for those, or less than 90% for both. 8% under 70%, and 16 states, as I mentioned earlier, did not post their reimbursement at all. So we just kind of put them in different groupings. This analysis can be found on the Bowman Family Foundation website. If you just look, this is like Exhibit D1, I think, out of the progress report for collaborative care. But this is just a way for us to think through how states are, sort of grouped relative to reimbursement to each other. Next slide, please. Okay, so as we went through all of this, and we've been looking at this, the Bowman Family Foundation has been looking at trends in collaborative care, economics of collaborative care for several years now. So we've gathered a lot of information. And as we pulled together the data from this particular study, the progress report, we kind of combined that with other elements of information we've collected over the past 3 or 4 years. And what we walk away with is kind of 4 key things here. One, the Medicaid reimbursement is very critical. If there is no Medicaid reimbursement for collaborative care in a state, or there is reimbursement, but it's very low, it's inadequate to really make it financially worthwhile to implement, you're going to see lower collaborative care use for all insured patients, Medicaid, Medicare, and commercial. And in a few states where Medicaid fee-for-service didn't reimburse collaborative care, the use was minimal in all of these plans. So again, the big takeaway is Medicaid reimbursement is tied very notably to the use of collaborative care under commercial or Medicare patients as well. Out-of-pocket expenses limit collaborative care use. So there's one thing we need to do to increase adoption, but if you have all providers providing collaborative care, but you still have the patient incentive to be in it and continue, and the out-of-pocket expenses will limit their interest in engaging and staying engaged. We've seen this now in a few studies that have been looking at at patients in collaborative care over time, and finding that many will drop out fairly quickly, in particular because of the out-of-pocket expense. Third, wider adoption would reduce total healthcare costs for all payers. And what we're seeing very consistently is the more collaborative care is there, the higher the savings in total healthcare costs. But we've got to see it adopted to get that outcome. And then lastly, this GO512, which is used by FQHCs and rural health clinic centers, are that has been taken away by Medicare this year. So this year, Medicare has allowed all organizations to use the primary billing codes in 994, 9234, and then 2214 to 2214. So what we still see, though, is that GO512 in and of itself will inhibit the use. Now, many FQHCs apparently have found ways to still deliver collaborative care using the PPS system, but we think this is a major takeaway that needs to be changed for all providers. Next slide, please. Okay, and Medicaid agencies can help drive this adoption. We think it's critical to drive it, and we've still got 14, 16 states out there that have inadequate. We believe maybe this has changed and we don't know it, but we think we're reasonably up to speed on it. There are a couple things Medicaid agencies can do. One, they can authorize fee-for-service reimbursement at rates at least equivalent to Medicare fee-for-service. A number of states already do this. Secondly, using the collaborative care billing codes in lieu of the 512, which I just mentioned in the previous slide. Third, using the same criteria for Medicaid, for patient eligibility, Medicare patient eligibility for Medicaid. And then lastly, requiring all MCOs in the state to do the same. Next slide. Okay, so in terms of implementing at scale, as I mentioned, we've got two very fascinating presenters coming up next. But one thing I wanted to mention is that Bowman Family Foundation has also produced a resource directory of organizations, collaborative care service organizations that can help provider organizations and health systems implement collaborative care, everything from consultation to full turnkey programs. And with that, I'm finished with my part of it. I'll turn to Keith.
Hi, everybody. Thank you for all that background information. It really does help paint a picture for the opportunity that exists with collaborative care for Medicaid programs. And what I'm representing, so I'm a psychiatrist and I'm the Chief Medical Officer for North Carolina's Division of Mental Health, Developmental Disabilities, and Substance Use Services, as well as an Associate Medical Director for our NC Medicaid program. And I want to give the perspective from state administration as to what's necessary in order to see, at least what we found in North Carolina, in order to see collaborative care become successful and be utilized more effectively than just let's turn on the codes and see what happens. So in 2018 is when North Carolina decided to make these part of our state plan on the Medicaid side. And we let it run largely on its own for several years and did not see significant uptick. It was pretty low, maybe 200 or so claims per month, which is just not much. COVID highlighted the need for high quality mental health and substance use disorder care to occur, particularly in primary care settings. Primary care was experiencing a significant burden related to the broad care changes that were happening in the COVID environment. And one of the places where we felt like that we could help was to incentivize and encourage the use of collaborative care to provide support for those primary care physicians and those primary care practices to provide evidence-based care and low barrier care for mental health and substance use conditions. So we had significant leadership at the state level through our CMO for NC Medicaid, and it included creating a consortium of stakeholders, including state government stakeholders, managed care, professional societies, and other entities that I'll go through when we get to the next slide. But what we did was really analyze why aren't we seeing more success by just turning this benefit on? What are the key barriers that providers are facing, and how can we as the state and providers and health plans work together to reduce those barriers. So we did a number of things, and we have a white paper published about this, and I've got the link at the bottom that covers all of these things and what we did in detail. But to highlight, we made sure that coverage across payers was aligned and consistent with Medicare. When you have special rules for Medicaid, when you have special rules for commercial, it's really hard for providers to implement that successfully. So we made sure to align with Medicare. We promoted coverage by all payers, including commercial payers. It's required for our Medicaid MCOs. It's also in our fee-for-service legacy system. And then we had commercial payers at the table with us. The Blue Cross Blue Shield is one of our dominant commercial payers in North Carolina. So it was relatively easy to work with just a handful of payers to try to get significant coverage. On the Medicaid side, we increased reimbursement to 120% of 2023 Medicare. That's a required rate floor for our health plans. We removed copays for beneficiaries. This is not an easy benefit for Medicaid beneficiaries to really understand exactly what's going on. There's a lot of work behind the scenes. It happens in a monthly way. It's hard to do these copays, and there is some significant potential for reduction and prevention of additional problems down the line. So we felt like we had some pretty good cover to remove copays here. We created a practice coaching and training model through North Carolina Area Health Education group in North Carolina. They partner and do practice coaching. They've done videos, they do conferences, they do a number of things to promote this model, really one-on-one with practices and then in a statewide way. We worked with our North Carolina Psychiatric Association to identify psychiatrists trained in and interested in becoming psychiatric consultants in this model, and had a matching program for primary care practices. We also developed a model contract that those practices could use for the psychiatrists. We also had our North Carolina State Psychiatric Access Line run through Duke University as an option for child psychiatry time, because that can be more challenging to find child psychiatrists who don't already have a very full panel. We developed and funded a free patient registry with the AIMS Center tailored to North Carolina, and that's operationalized by Community Care of North Carolina, which is an organization that represents a number of our independent primary care practices. We successfully secured $5 million in capacity building from our legislature. This is sort of one of the more ambitious things that we were able to do for primary care providers, and we're able to operationalize that through CCNC as well. And then we promoted collaborative care at key health professional and provider practice events. Next slide. This was the consortium, so I'll explain what some of these mean. DMH-DDS-US is our state mental health authority and substance use authority. Obviously, Medicaid, I've explained AHEC and CCNC. The North Carolina Academy of Family Physicians, the North Carolina Psychiatric Association, and NCPEDS were all at the table. Those are our professional societies. We also had the North Carolina Healthcare Association, which is our large health systems association, and our FQHC association there at the bottom, all at the table, helping us to figure out what are the barriers, how do we solve those barriers, once we solve them, how do we promote this. This has been going on since 2022, and we still meet quarterly today to continue to assess the success of this program. Next slide. So I'm going to talk a little bit about the capacity building program. I know not everybody will have $5 million sitting around to do this, but there are a number of ways to consider financial incentives. And given that this is an overall cost saver, your legislatures may be interested in supporting startup, because startup seems to be one of the critical barriers for primary care practices. So many providers were interested but lacked the ability to have startup resources, even though after 6 months to a year, if you've got the reimbursement right, it's likely that this will be self-sustaining without significant difficulty for providers. But the hiring and the training of that behavioral health care manager seem to be one of the biggest barriers for providers. There's an onboarding and productivity lag from hire until they've got a full caseload that's self-sustaining. So we requested and received the $5 million in one-time funding from our legislature in 2024. We contracted with CCNC, which is a very well-established North Carolina-based entity, to accept provider applications for these dollars, to make awards, to distribute the funds, and to monitor the outcomes. Of note, the state share is not Medicaid matchable for what goes to the provider, but it is matchable for the administrative overhead that went to CCNC as our entity to administer this program for us, and that's a one-to-one administrative match. We had awards categorized in 3 different phases. The majority of awards, and I'll show you some of our outcomes with this, were $50,000 for practices who were newly implementing the model in-house, $30,000 for those that were doing it in-house but expanding it to usually another behavioral health care manager or to new sites, and then $20,000 for practices who are newly implementing with a turnkey vendor that has significantly less overhead for providers. It was a milestone-based process, and so you didn't get the full award immediately. There were several things that you needed to do in order to get the first allotment and the second allotment, and for that $50K, there was a third allotment. But typically that was demonstrate significant engagement, identify a practice champion, make sure you've got your board on board with the process, go through some TA process, including a pro forma to make sure you know what you're getting into. Then they get the money that really allows them to go out and hire and sustain that care manager. They get the second bolus for the $50K when they've got that care manager on board, and then they get the final bolus when they have a panel of 20 or more. Three awards were the max per primary care entity, and it could cover up to 3 sites. We wanted to make sure we had good geographic and other spread across the state and didn't want to concentrate resources in too few places. We also considered the economic distress of the county that the practice was in, rurality, and other resource needs to prioritize practices for both outreach and funding. CCNC did significant outreach, as did NCAHEC for us, to make sure that this was promoted. Next slide. This just gives you, if you want to take a picture of it, takes you to the site for our collaborative care program, and you're welcome to peruse that. Next slide. So we've seen significant uptick in utilization. We had, again, very minimal growth, kind of hovering 200 to 400 beneficiaries per month within the Medicaid program between 2019 and early 2023. We really saw the benefits of our low barrier approach start to kick in mid-2023, even though we had not started our capacity building program yet, which was largely implemented from 2024 through the end of 2025. We're largely through that $5 million at this point. So since we've done this, we've seen pretty steady but predictable growth. So around a 3.5 fold increase between mid-2023 and the end of 2025. It requires a coordinated statewide effort to drive implementation and sustain programs. You need support from key reliable resources in the state as well as your health plans. But generally, we see collaborative care to be a low-risk covered benefit with a proven ROI, such that it doesn't require a lot of heartache from the state when it comes to worries about fraud, waste, and abuse or inappropriate utilization. Next slide. This is some of our dashboard for our capacity building program. I just want to highlight some of the things we paid attention to. North Carolina is a pretty dominantly family practice state, so we've got a lot of family medicine practices, but also pediatrics and internal medicine were some of our core awardees. We did permit OBGYN practices who are serving as an advanced medical home in North Carolina, but did not get any applications there. We also had awards for FQHCs, rural health centers, and one health department. As you can see, most were in phase 1, which is that newly launching $50K in-house. We had, this is as of last month, over 80 awarded practices and 110 locations. And yeah, I think that largely, oh, and most of them were independently owned. There were a few that were hospital or health system owned. Next slide. And this is some of our results. So for our awardees in the capacity building program, they do have to report out to CCNC, who reports to us what some of their results are. We want to see that they're billing effectively and efficiently. So we track that, but we also really wanted to look at outcomes. This doesn't say what condition was being monitored, because they could pick a range of conditions, as you can with collaborative care. So it could be depression, it could be generalized anxiety disorder, it could be PTSD. But what we see is broad increases in those who are being served. So this first one is active cases versus new cases. So it's this steady build as we're building into practices that are actually implementing. And then on the right, we see cases with improvement and cases in remission. And so even with just, May is incomplete data, but April we had, probably under 60 practices implementing yet who were reporting out. And we already have, hundreds to a couple of thousands of folks who are actively doing better. And then when you consider what had been done in previous months, this is a pretty impactful tool for primary care practices to have and to prevent subsequent disability and impairment. Next slide. So my key lessons, and then I'll hand it over to Leanne, are you need champions at the state and provider levels. You need low barrier coverage, so don't add a bunch of stuff onto it. You need low barrier implementation options, so provide a lot of help and resources to providers that may not have all the tools immediately available to them. You need to do direct provider outreach and targeting, as well as technical assistance, and then provide startup support or financial assistance incentives when able. And with that, I'm going to hand it off.
Good morning, everyone. Good morning from San Diego. I'm Leanne Wardlow, Senior Director of Clinical Research at West Health Institute. And today I want to share with you what we've learned from running one of the larger real-world implementations of the collaborative care model and what it means for you as Medicaid offices thinking about how to make behavioral health integration actually work for your members. Next slide. So quickly, West Health is a nonprofit organization based in San Diego. We're nonpartisan. We don't take industry funding. Our singular focus is making healthcare affordable and accessible, particularly for seniors and vulnerable populations. Behavioral health integration is our top priority right now because we believe it's one of the highest leverage things in the healthcare system that can be done to reduce cost and improve outcomes simultaneously. We think, or we work at the intersection of implementation, quality measurement, and policy, which puts us in a useful position to connect what happens on the ground in clinics with what needs to happen at the policy level. Next slide. So I would like to share why we chose a Northwestern, why we chose to invest in Northwestern, and what we were trying to accomplish. So this wasn't really just about serving Northwestern's patients, as important as that is. The goal from the beginning was to do this work alongside a major health system so that we could learn everything that we could about what it actually takes to stand up and implement collaborative care at scale in the real world, so that we could then share those learnings and create other tools and resources to help others and make it easier for others to do. The accelerator at Northwestern itself spans 80 plus clinics, so all of primary care at Northwestern across the Chicago metro area, with a target population or enrollment of 10,000 patients by July 2027. And this work has really generated significant amount of hard-won implementation knowledge, which is what I want to share with you next. Next slide. So I'm going to just boil it down to 3 lessons. 3 core lessons. First is primary care must lead, not just refer. If PCPs aren't active participants, your program isn't going to function well. Second, data and data systems have to support primary care, not just track program metrics for administrators. You need to create a closed feedback loop to sustain PCP trust and engagement. And third, financial sustainability requires payer actions. So as you've heard already, the savings are real and they accrue across time and across payer types. And Medicaid coverage and reimbursement rates are among the most powerful tools available to make this model viable for the practices serving your members. Next slide. So primary care. One of the clearest things we've learned is that programs struggle when they're designed as psychiatry-led programs that feed into primary care. That structure really works against PCP engagement. And PCPs need to be the clinical lead, and they are the billing provider. That's really the design of the model and what makes it work. So PCPs need to participate. A clear practice script for verbally consenting patients is important. Without that, the conversation tends to get avoided. You need to have simple, frictionless referral criteria. So any ambiguity around eligibility leads to PCPs opting out. Like I said before, you need to have a closed feedback loop on what happens to their patients. If there's no feedback, that really erodes trust quickly. And that trust and those relationships is what drives future referrals. I would say another important part is ongoing training for PCPs and their staff, not a one-time orientation, because CoCM and collaborative care is a genuinely new workflow for those clinics. But on the good news side, evidence shows CoCM actually reduces PCP burnout and burden when it's done right. So surveys of PCPs consistently show strong support for the model among providers working with complex patients. And the research points to reduce burnout and increase satisfaction once they are engaged, understand the model, and are getting that feedback and that data about what's happening to their patients. So CoCM really distributes the workload and replaces the frustration of failed specialty referrals with seamless consultation. Next slide. So the workflow for collaborative care is population level screening in primary care, referring into the program, enrolling, monitoring outcomes, and then having feeding data back to primary care. And that loop sounds straightforward, but it's where many programs run into trouble. In our accelerator, we learned firsthand that having inconsistent definitions of simple things like what is a referral across systems, teams, and time periods can make your data difficult to work with and undermine your ability to manage the program well. So I would recommend bringing stakeholders together. That includes primary care, your social work staff, your psychiatry staff, to create those agreed upon data definitions early and ensure workflows are created to capture that data and to report it back to those who need it. So don't assume that everybody will define a referral the same way, that everybody will define enrollment the same way. Make sure that you get buy-in early on. And so you also need, as my colleague just said, a low-lift referral and enrollment process. So again, make sure all of your stakeholders understand what the program is designed to treat. So what are the conditions that it's meant to treat? Who's eligible, who's not eligible, how referrals are made, and what happens after a referral is made. So working together across those stakeholder groups to define those things and make sure they're clearly understood and that referrals are then easy is going to really lead to better uptake over time. I would also lastly say PCP level feedback reports. So what is happening to their particular patients should be built into the program design from day one. Next slide. So the financial case for CoCM is well established. CoCM or savings come from, as you've heard, fewer ED visits, fewer avoidable hospitalizations, better management of comorbid physical conditions, like especially the chronic conditions like diabetes and cardiovascular disease, and those grow over time. And what I want to emphasize is that those savings don't materialize if programs can't get off the ground financially. So most primary care practices, especially those serving Medicaid populations, they can't sustain a CoCM program without adequate reimbursement. And your coverage and rate decisions play a foundational role in whether this model reaches the people you want it to. So what you can do that makes a real difference, cover the CoCM billing codes first and foremost, set reimbursement rates that make the model viable for practices, such as our North Carolina colleagues on today's panel, And I'd encourage you to ask about their experience. Build data infrastructure requirements into your contracts so programs have the systems they need, and invest in technical assistance and training so practices aren't navigating this on their own. So the model works, we have the evidence, we have the real world experience, and we have the tools to help. And we'd love to talk to you about what we could do and to help you in your state. Thank you.
Great. Thank you, Lan. Terrific stuff. And so we had an ambitious panel here to bring all this helpful information in. So we're running a little short in terms of questions, but we'll get to one or two if we can. But again, thank you each for great presentations. So the key takeaways here, collaborative care model is effective and reduces cost according to numerous studies and real world evidence. And so again, the fear that, sort of we initially started this with, that it would drive up cost has not only not borne out, but I think there's legitimate, credible evidence that there's an opportunity for savings here in a way that desperately needed. I think for all the reasons that are well apparent. Uptake of the model has been slow because of the startup costs at the practice level and coverage barriers. There are terrific examples of successfully implementing, and you just heard one from Leanne, at both the scale in terms of a network, but also scale with the state, as was presented on North Carolina. And there's key strategies for successful implementation, making it easy and affordable for patients. This is something we haven't talked a lot about on this call, but I was involved in an effort in Maryland, for example, to reduce copays for plans for patients. So as one barrier, direct provider outreach and technical assistance. That was part of what you heard from Keith. Ease of implementation, startup, financial incentives. Again, don't let perfect be the enemy of the good. If that's not realistic in your state, we get it, but that's certainly one way to skin the cat here. As Leanne just said, primary care must lead, data systems must support them, and financial sustainability requires payer action. Because although as Keith said, it's ultimately self-sustaining. The front end piece of this is often a burden. And final point that I really wanted to drive home. This is a strategic opportunity. We understand the context in terms of state budgets. However, this is an intervention that ultimately is shown to actually reduce costs and improve outcomes, and that's what's so exciting about it, and why we're grateful for the partners we have on this panel to really help share this information, not just with the public, but also with key decision makers in states, especially to hopefully drive that. So. Those are our key takeaways. With that, we're have time for just a couple of questions. The first I'll share, these again came in advance. What outcomes should clinics, provider systems, or payers for that matter be monitoring? And I think that's probably for any of you, but Leanne, I thought of you with this question in particular. What outcomes should we be looking for?
Well, I might even start with processes. So start with, are you screening at a population level? And look at, make some estimates to start about the prevalence rates in your area, and make sure that you're capturing, what you would expect. And then I would be looking at things like engagement. So time from a screening and identification to actually being connected to somebody in a collaborative care program, and then time from there to how long are they in the program, what are your clinical outcomes, so when are you getting clinical response or remission, what percentage of your population, and over what time. Those are some of what I would call the health metrics of the program.
Great, thanks. Keith, Michael, anything to add to that?
I would just say that on the outcomes, I mean, the categories of outcomes we typically look at are clinical, financial, and sort of satisfaction or health equity. And I think for the clinical progress, measuring, the many systems or providers will use a couple of standardized pools that we're all familiar with, PHQ, GAD, and there are others involved. But those are, you've got to be able to demonstrate that people are getting better under this model than they were before. I think also from the financial standpoint, you've got to be able to demonstrate to your organization that you're able to sustain this model, because it's not something that others will continue to fund, in perpetuity. You've got to get the model stabilized and able to earn its keep, basically, within the organization. I would also add referrals. I think Leanne may have touched on this, but if providers aren't referring patients into collaborative care, then you've got a major problem from that point forward. You're not going to be able to make everything else work. And then PCP acceptance, provider acceptance of this. And again, I think Leanne and maybe Keith mentioned this, but primary care providers are already in over their heads. They've got way more than they can deal with. This has to be made easy. It's kind of behavior change 101. Make it easy. And you've got to make it easy for providers to adopt this. I'll stop there.
I think from the state perspective, what was most important for us was monitoring utilization, not for overutilization, but underutilization. And then to see that as actually a pretty core problem that we needed to solve, given the demonstrated ROI on this and the demonstrated benefits to the actual primary care clinicians and their patients when implemented.
Great point, Keith. And I'll just, again, remind folks about Keith's slides on remission rates and such. I thought that was really, really impressive and helpful for me to visualize as well. Okay, we have time for maybe a quick question. I'll just let everyone know we do intend to, I know folks are sending in questions, so we do intend to answer some questions as a follow-up, and we'll share the webinar as well. So thank you for asking those, and apologies that we're not able to answer them right now. I guess quick one. I hope at the end here. What are the biggest operational financial challenges to implementing it? So this is really financial piece.
I'll say quickly for us, it's being financially viable really requires understanding your social work or your behavioral health care manager panels and really optimizing those. And you'd be surprised at how complicated it is just to even agree on who is on a panel and who is not on a panel, and who should be, moved off a panel and when, but really optimizing those and making sure that people on your panel are receiving the services regularly and being billed is what's going to keep you financially viable.
Yeah, and that startup is pretty critical to support providers with. It's the beginning of this that requires some significant investments. And then for small providers, especially if they lose their behavioral health care manager, that becomes a really critical thing for them to try to figure out. So those supports from the state or other entities to create an easy pipeline for that can be really important from a workforce perspective.
Great. Well, thank you. Well, we're just about at time, so let me start by thanking our panelists, not just for terrific webinar and sharing all this information, but I'm aware of the wonderful work you've done in your respective roles, and so greatly appreciated the way I think you and your organizations have helped just drive the field, both mental health and addiction forward through your work on collaborative care. So thank you. Thank you also to everyone that's joined us. The interest in this area is really, really important because there's a lot of work to do, as has been discussed. So thank you again, and have a wonderful rest of your day. Thank you.
Thank you.
Thanks all.